The next two presenters are Brad Rogers. Brad is the head of Telehealthcare and product development for Simplicare and has worked with and advised buying consortiums and local authorities on telehealthcare development and provision. And Mark Reynolds is a GP who was secretary, then chairman of the National Association of GP Cooperatives, representing approximately 30,000 GPs across the UK until they ceased operation with the introduction of the GMS GP contract. He's been on a number of DH and NHS advisory groups and received an MBE for his services to out-of-hours care. And they'll be talking to us about the integration of telehealthcare and technology into services. Thank you.
Good afternoon, everyone. I'd like to say thank you to Jo and her team for our colleagues from Kent. We're just about to give you a presentation on the integration of telehealthcare and technology into services. Let me introduce you to Simplicare. We are the care division of Commercial Services Trading, formerly known as KCC Commercial Services. Within that care division, we provide assistive care technologies around telecare, telehealth, at-home domiciliary care, and we also have a store providing mobility products and an e-commerce website. So the problem that we find is traditionally funded by housing providers for telecare. Which budget do we look for health or social care? How is it funded into housing provision? How do we provide provision under housing benefit? Which budget does it get paid out of for telecare or for a telehealth provision? Traditional methods of sheltered housing telecare system ward and call systems are a pull cord, smoke detectors linked to a ward and call system. We've got to get away from those type of systems. The on-site warden, they're probably off-site now. So we've got to get away from that traditional method. So how do we come up with a solution of integrating these services? So we have a hub in the home, in a sheltered housing, which sits on an IP network. That could be Wi-Fi or it could be 3G. This system allows you to have a housing provider helpline to contact someone out of hours if you have a problem with your gas or electricity. It's also linked into your domiciliary home care provider, so you can contact them. It's linked into our clinical contact centre, so we have Telecare and telehealth devices via Bluetooth and radio signals, so we can gather that information. That information comes back to our clinical contact centre with our partners Integrated Care 24, and from there we can populate the information gathered from these devices into the NHS entry network, and we can pass that information into clinical systems such as a GP system called EMIS. We can also populate telecare information on falls, trips, slips, enuresis, bedwetting or epilepsy, and we can integrate that back into the electronic social care register. So it's true integration between health and social care, alarms and information coming back into us. We also do health and medication reminder services, so we can remind people to take their telehealth readings. We can say, please take your medication, please take your blood pressure, and that information comes streaming back into us. The other thing that's quite important with this home hub is the control of lights, televisions, curtains for people with PMLD, learning difficulties or physical disability. The home hub itself, you can see on the left, is a touchscreen service, so it can be the integration into a service user. We can customize that for colors and graphics for people with sight issues. We could also brand company logos on there for housing providers. We could also interface into door entry systems, both video entry and audio entry systems, and integrate into fire alarm, landlord system fire alarms within a building. As I said, all the connections into there are on an IP network. So the system itself has direct connections into the service centre. So it acts as an emergency telecare device. It's fully telehealth enabled. The health and wellbeing reminding service is very much linked into our medication devices. So we can have a Dosset box which has a carousel on there, remind people to take the medication. If they forget their medication, it comes back to our clinical contact centre. We speak to them and say, Mrs. Smith, please take your medication. If you haven't, we can also provide video conferencing through the panel. We can look at the individual or the client and see if they're looking well, and generally by face-to-face contact and communication to them, we can generally tell if they are taking their medication. The connection into the clinical triage centre, we have GPs and we have nurses on call, and the contact centre also provides 1-1 services throughout the country as well. So call handling based on emergency and non-emergency repairs. You can contact your housing provider and you can get the help that you need. You can contact another provider around health. You can also speak to your local GP and book in a visit to your doctor. The full clinical triage service that we do back at the contact centre links in with the integrated provision that Joe talked about. So we could get information back to our GP service and really get at the heart of what's going on with the individual. The system sits within the NHS N3 network. The links that we've got into there link into clinical systems such as the EMIS. To get that information out of there, we can populate summary care records. We can also populate information back to the electronic social care register. The GP, rather than being bombarded by readings of blood pressure and glucose, we can set parameters so we only contact the GP or the community matron with the information that's necessary around that client. Single point of access. We have a single point of access into our system. I know Joe talked about Kent doesn't have a single point of access for integration because of all the different CCGs, but we have a single point of access into our clinical contact centre that would allow you to speak to your housing provider, your domiciliary care provider if necessary. We can dispatch ambulances directly through NHS care pathways. So basically it's about a seamless service delivery from one end to the other. Our systems are fully accredited by the Telecare Services Association, and we are members of the London Telecare Group. Our partners, Health Alert, are part of IC24. They have a contact centre in Ashford. It is backed up by disaster recovery in Ipswich, so it's quite robust in the service delivery model. This system as well is to promote housing support. We don't traditionally know where provisions for Telecare and Telehealth are going, how the funding's going through 3 million lives. This system is to see if we can integrate into housing benefit to allow housing providers to provide such a system under housing benefit to add all the additional benefits of long-term conditions, so CCGs can integrate telehealth into this device, and social care can have telecare devices into this system. I'd like to hand you over to Dr. Mark Reynolds, who's going to take you through the clinical triage, give you a bit more insight into the 3 million lives in WSD that we've done for Kent County Council, and a little bit of insight into that side of the service. Mark.
Thanks, Brad, and good afternoon, everybody. And thank you for the introduction earlier. Let me just move this part on a little bit. There we go. So where have we and where have I come from? Well, I'm a GP, Maidstone, 20 years as a GP, very involved in the co-op movement. And I'm in no way an expert in telecare and telehealth. I'm a fairly recent convert to the concept. And what has really excited me is working with our partners to look at what we can do to care for vulnerable people and keep them at home as cost effectively as possible with a single point of access in a truly integrated fashion. Forgive me, I'm getting so old I have to put my glasses on these days. And where all our original cooperatives have coalesced to become integrated Care 24. So GP membership-based, social enterprise model, not-for-profit, and out of hours can be really good. Who reads the Daily Mail here? Good. Good. I didn't see any hands go up, but so we've had a lot of flack lately, but out of hours can and should be good. We provide good services, and so can 111. And it's all that huge experience of working with clinicians and primary care groups, CCGs over the years, that is a really exciting potential link with this model. And this is the thing that's really lit my fire, in fact, because what have we got? We have got a contact centre that is stuffed full of people, experienced call handlers, people who can operate NHS pathways and assess people, nurses and GPs, as well as other people in there, of course, too. So when you look at all of that on tap 24/7, if someone at home has a problem, presses an alarm, there's assistance available from the basic level as Brad has described, which is to pass a message on about a difficulty with housing through to the necessary people straight away, so the patient, as I insist on calling him, doesn't have to make any other calls, right through to a call coming through in the middle of the night where in fact it turns out they've got something medically wrong with them, and we've got all the people right there to help them with that problem straight away. This is what it's all about for us. And in here, I've heard today from some of the people who visited us how they have one provider for Telecare, one provider for telehealth. The systems don't talk to each other. The information doesn't get back to GPs very easily, doesn't get to social care terribly easily. And it's the thought of pulling all that together with our model that I think is really intriguing. Of course, it's all accessed through N3, which makes it possible, and that's a fairly unique situation. One of the things on here you may not be familiar with, forgive me, is Share My Care, which is another web-based special note system that's available to anybody with an N3 network, and this has been in use in East Kent for ages. There are competitors out there, but it's a way that flags can be put on a patient's record with care plans, care records, right through to palliative care advice and notes for the people who are dealing with that patient and who have the right permissions to view. It's something we've traditionally provided free in our contract areas, and it works very well. And that's another part of the jigsaw to making sure that people get the right sort of care when they need it. We're also extremely interested in the 3 million lives, and I'll talk a little bit more about that when we think a little bit about the whole system demonstrator. This is what is there in our contact centre at the moment. We do provide 111, and we provide it pretty well. In fact, very well. We provide pathways. So when you look at all of those things that could be pulled together, plus the Telecare and telehealth experience, many of these services are active, some are imminent. You look at the picture that we can care for someone from a very low level of dependency right through to something much more and assist them with emergencies right there and right then. What has struck me in my recent conversion to the concept of Telecare and telehealth is that, in fact, the primary care resource is going to flatline, isn't it, over the next 5 or 10 years. There's not going to be much more resource out there. There aren't going to be that many more GPs, if any, not that much more in the way of community services. And unfortunately, that isn't at all the case for people with long-term conditions, elderly. So the two lines are sort of going to do that, aren't they? There's our resource, and there's the numbers of people becoming more poorly, needing to be kept at home, safe and comfortable and secure, if it is at all possible to do so. And in that gap, we need all the help that we can get. And I've become convinced that Telecare and telehealth can assist in keeping people confidently in their own homes. So the whole system demonstrator pilot, this is one of a series of pieces of research. Is anybody familiar with this piece of work out there? That's a relief. So anyway, what it was it's a fairly large-scale trial of telehealth interventions for needy patients with a control group and an intervention group. These headline figures are pretty amazing, aren't they? When you look at that, a 45% reduction in mortality rates, big reductions in admission, reductions in lengths of stay in the group where telehealth and telecare was introduced in a joined up fashion. This, of course, has been spun. This is the Department of Health summary of the figures, and it may not be as good as that everywhere, but there's certainly something in it. And what was done for these groups of patients was it was about 1,500 had, in 3 conditions, there was heart failure, diabetes and COPD, had the appropriate devices fitted in with a hub in their homes. The other 1,500 had a light touch visit to assess whether they were necessary or not. They were offered that sort of input after the end of the year of the study. And then the outcomes for those 2 groups of nearly 1,500 on each side of the trial were compared a year later. And these are the stark figures that came out at the end of that year. Many of the previous studies, I understand, about these sorts of intervention have been quite small scale, sort of 20 patients, 50 patients, 100 patients. And you need to do this type of intervention at scale, we believe, to make a population size difference. In the control group, there was an unexpected rise in admissions and a change in the first month, possibly stimulated by the fact that they were visited for the soft touch assessment, and so their care actually was enhanced for a spell. But at the end of the year, these sorts of differences were still apparent. And it was this, really, that has got me going from being a slightly cynical grey-haired GP into a considerable enthusiast for this type of intervention. And what I'd like you guys to concentrate on here really is the yellow bar at the bottom of this slide, because this is our proposition to commissioners that we can, from the simplest caller-initiated telecare intervention right through to complex telehealth with immediate clinical triage of any sudden deterioration in a patient, deal with it. And we can deal with it in such a way that it's entered into an IT system that communicates with EMIS and Vision and can communicate with System 1. It's ready to communicate with social care systems. It's there for call handlers to transmit and for GPs to receive in a way that they wish to. And added to that, there's the Share My Care possibility, so that any decisions that are taken are done so informed by detailed notes from the patient's own GP practice about potential next steps for that patient who's called and who is in trouble. And I think that's significant, and I think that's different, and I think that's exciting. Okay, where have we got to now? And this is what it's all about. And my goodness me, as the population, as everybody has said, the aim is to keep people out of hospital. They don't want to be in hospital. They want to be supported and confident at home. And one of the things that happens to my patients as they get older and more vulnerable and more wobbly and more anxious is they feel anxious at home. And we hear from people who have this sort of intervention at home, the sorts of devices that we're proposing, they feel much more secure. They know that if they're in trouble, they've got someone that will be in touch with them quickly who can sort them out from the simplest intervention to a complex clinical interaction and the dispatch of an ambulance, if necessary, all in one shot. So that's us to our presentation, and we would welcome any questions. Thank you.
Thanks very much, Brad and Mark. Do we have any questions? No? They've all been answered. Yes?
There's a question over there. I went through that a bit quickly, didn't I?
Hello. I'm Tony Moore, came from Derbyshire. So I don't know too much about the IT techie stuff, but what you're saying is it possible to integrate adult social care IT systems into a general practice IT system so that the complete picture, say for example, of a frail, elderly, vulnerable person is known to the practice? Not only the practice details, but the social care provided to that same individual as well.
That's correct. We can populate the electronic social care register, for example, Swift or CareWorks, with a management of a slip, trip or a fall, a Telecare device going off, so the social worker would go into the electronic social care register and know about the incident. The same with telehealth. If it peaks out of a parameter that's set by either a community matron or a GP, that we can actually send that information via the N3 network into clinical systems. So we can do both of those.
Information governance issues.
The information governance issues, because the clinical contact centre sits within the N3 network, it's been fully signed off under IG for NHS.
And the other thing is when the help is installed, the patient gives permission for their records to be shared, and that permission is recorded electronically on the system, so you can see straight away that the patient has given permission. When you're working in systems currently, before you access, for instance, a summary care record, you have to ask the question. But with the model that we're proposing, the patient will already have had explained to them that your information will be shared amongst providers. And for me, that's, as a Caldecott Guardian, that's good enough.
Yeah.